My second introduction to the Bicon system was a telephone conversation with the next speaker, Bill Grippo, who's a periodontist. He's in private practice in Napa in California. He's used the Driscoll stroke Stryker stroke Bicon implant since 1985. Bill, be our guest.
My presentation is going to be very short, and what I was asked to do is really to show some long-term radiographs of cases that were done and make some comments about those cases. All these cases that you'll see will be two-stage surgical, and that's because when these were done, that's all we were doing was two-stage. I will tell you that now I do pretty much exclusively one stage, unless there's some unusual reason, some need for some grafting or other things like that. And I think the one stage is working extremely well and haven't had any major problems with it at all. For those of you who've heard me speak before, I used to follow these along in terms of keeping track of numbers and failures, et cetera, and I stopped at about 15 years. And the results of those 15 years are what you see on the board. One of the interesting things that doesn't show on the slide, and I don't know if it's in the next slide, is that we didn't have a greater failure rate in the maxilla. In fact, we had a slightly greater failure rate in the mandible than we did in the maxilla. And it's always kind of fascinated me because every article I've ever written or read about implants is that the failure rate in the maxilla is always greater. And I don't know if that's because of the design of this implant or what the actual reason is, but I think that it goes to show that if we have something that's designed well, that there really may indeed not be any difference. The patients that we saw for these 15 years were actually ranged in ages from about 17 or 18 to 94. The x-rays that you'll see today, unfortunately, don't span that quite an age group. It'll be more in the range of 21 to 75. And that's because when I started to go back and try to get some of these people that we had originally done in the early years, most of them had either moved or passed away. So we did the best we could. Most of the slides that you'll see will be in the 14 to 15 year range. The slide on the right is at second stage. The slide on the far left is at 14 years. I don't know how well you can see these. I don't know if we can see the pointer, but you can see that the bone level is really maintained around the abutment. We're not losing bone. Everything is staying extremely stable. And I would say that for the most part, this is what we're seeing with the implants. It was interesting because last night we were talking, and I was talking to Dr. Abdullah, and the question came up was, we know that the implant was designed to be countersunk, about 3 millimeters. And in those situations, when we do countersink the implant, we're seeing bone maintenance very well. The question was, if the implant is not countersunk, if it's level with the bone or perhaps slightly above the level of the bone, what's happening then? Well, what seems to be the consensus, and Dr. Chapman alluded to that in his presentation, is that in some cases we're not only seeing that that bone level is still maintained, but that the bone level actually comes up on some of these implants and covers the shoulder of the implant. So this is an overdenture situation. Again, 14-year follow-up. This is a bar-connected overdenture. We're not seeing any significant bone damage around the necks of these implants. Another case, 2 posterior. As you can see, I was a little dyslexic when I placed the one not too straight there, but you can see the bone levels are maintained. Now, on the right side, you can see that implant is not placed subcrestally. You can see on the left slide that we've not had any significant change in the bone level, even though it's not been placed subcrestally. Another, this is the same, different lady here. This is an ortho case where we had to sneak some implants into a space that was left by the